Welcome back. We are heading into our final panel. Thank you for sticking with us for this whole day, and we're in the home stretch now. It is my pleasure to introduce you to the panel that we have this afternoon. And again, just like the previous panel, we have some folks who've been wearing various hats in their careers. And so they're going to be reacting to what we heard today and to what we saw in the polling and their read of the blueprint to give us some other final thoughts as we begin to close this program. I want to start with Dr. Jennifer Graff. She's Senior Director of Professional Affairs at the Academy of Managed Care Pharmacy. She has more than 20 years of managed care leadership and research experience. She was previously with the National Pharmaceutical Council, and she joined them in 2009, where she served as Vice President of Policy and Research, and she led policy initiatives, partnerships, and research to advance the use of high-quality evidence to inform healthcare decision-making. Prior to that, she was a therapeutic area team lead for respiratory and autoimmune health, economic, and outcomes research activities at MedImmune, and she also oversaw global outcomes research at Pfizer Pharmaceuticals. Next, we have Dr. Joey Mattingly, who's an associate professor of pharmaceutical health services research at the University of Maryland in Baltimore. He currently serves in the Department of Pharmacy Practice and Science. And he teaches business strategy to students in the professional program and is a strategic consultant for the University of Maryland Medical Center Department of Pharmacy. And in addition to his work as a faculty member, he serves as the Director of Operations for the Patients Program at the University of Maryland. And then lastly, but certainly not least, we have Ms. Melanie Parrish. She is Senior Director of Education and Strategic Partnerships at the American Kidney Fund. Her focus at the AKF is designing programs that increase awareness of kidney disease and its common causes. She engages people living with kidney disease to successfully manage their comorbidities and on effective prevention among at-risk populations throughout the United States. She also leads the creation and development of evidence-based programs and resources for people living with kidney disease, their caregivers, and renal professionals. So thank you all very much for joining us today. And as I said, we recognize that you have worn various hats in your careers. And today we're asking you to use that collective knowledge that you have to help us think about PC-CIS and the blueprint and how we move forward. And I know that you've been listening in on some of the sessions today, that you are aware of some of the discussions that took place in our listening sessions that we have. And we're going to share, I think, some of the information is going to be shared with you about the polls that we took earlier today to kind of get a feel for what the audience is thinking about. And so I want to just kind of turn to you and just ask, what's your gut reaction? How are you feeling about this? And so, Jen, I'm going to start with you. What you've been learning a lot about this over the last few weeks since we've engaged you in becoming involved in part of this process and the AMCP. Tell us what you think about all of this and how you think your members at AMCP will react to something like this.
Great. Thanks, Eleanor, and thank you to National Health Council for having us today. This is exciting because if you think about what matters to patients, that means that we can align payment policies and coverage guidelines aligned with that. AMCP are the managed care clinical and pharmacy directors that often are determining what your coverage policies are for your medications, determining what's on coverage, what's not covered, how it's tiered, which subpopulations, and how it's covered. So as I think through this, and as our members have been thinking through this, understanding what really matters to the patient helps provide that color picture, is the way I've heard one of our members describe this. They look at all the clinical evidence because they are trained to look at PubMed and look at p-values and all the other evidence-based measures. And that gives you a very black or white picture. And by understanding what matters to patients, that helps to fill in the color. So having a more defined process through the PC-CIS program, I think really helps incorporate that. And we're already seeing some groups are engaging in this. For instance, a plan in Pittsburgh, UPMC, engages patients and other stakeholders to figure out what endpoint they even wanted to include in a value-based contract. And they went out and did all of that work to better understand that, perhaps in not as an extensive way. And it completely changed what they used as a measure for their value-based contracts. So the more that these items are available, the better we can pay for what actually matters to patients.
Thank you. Thanks. So Melly, can we have you jump in next?
Sure. I want to tell you again, thank you so much for having me. And I really enjoyed listening to the dialogue and the presentations today. You know, I see a lot of, I think, parallels maybe with how we're thinking at American Kidney Fund with how the audience has reacted to some of the questions. And it's just very interesting that American Kidney Fund, we recently conducted a poll among our pool of patients for whom we provide financial assistance and asks them a variety of questions about how they feel about the transplant process, how much they've learned, how much they know, and also about home dialysis. And you know, we developed the survey thinking, you know, a few things that we were expecting to find, and we interestingly just received the results about 2 weeks ago. And many things that we were expecting, we did not find, and it was very different. And we conducted this poll with the thought of using the information as a foundation for developing new programming and how to help our kidney disease patients and caregivers. And, you know, just putting the patient first and making things patient-centered is just so critical. Had we not conducted this survey, I am sure we would have probably gone in a different direction, maybe just based on assumptions, anecdotes, also smaller poll feedback, and actually not taking into consideration some of the diversity within the pool of patients that we serve. And I don't mean just racial diversity, income diversity, age diversity. And I think this blueprint, I think, helps sets the tone for how to think about groups of people that you are serving and patient populations, so that there aren't a lot of assumptions made, and we're not thinking about it in terms of what we think they should have necessarily, but somehow coupling that with what is important to patients, what they need, and how we can better serve them and meet those needs.
Joey, I'm going to go to you next. You're wearing a few different hats here as an academic researcher, and we just finished the researcher panel having that discussion, but you've also been involved in discussions about drug pricing and value assessment and some of the practitioner kinds of questions that might come up for the pharmacy profession or pharmacy decision makers. Can you jump in with your immediate reactions and thoughts?
Yeah, thank you again, Eleanor, and again to the whole group for everyone sticking with us today. My initial reaction is that I'm hopeful that this provides some framework, some organization really around these concepts. Mainly, you know, patients and families have been telling us their preferences since the beginning of time. Like when a young mother quits her job because it doesn't allow for her to you know, address some of the needs at home, or a family makes a decision, you know, to not take a medication because they can't afford it, or whatever the decision is, that's revealing a preference. You know, it's revealing things that matter to them. It's just whether or not we want to listen. And so what I'm hoping is that, you know, having an organization around this, it gets us all to look at one place and say, okay, here's where we have it listed. Can we, you know, look at this list and identify, is there anything missing, right? And then, okay, we've got a list of things. Maybe we know qualitatively all the things that are in this environment. Now, quantitatively, how impactful are each one, and, you know, what's the most important, the least important, and how is it different? So anyway, I'm excited about the organization more than anything, because I do think the frustrating thing is it's like, this isn't new. Like we've been, you know, patients have been trying to tell us. It's just whether or not we choose to listen.
That's actually quite well put. It's a matter of figuring out whether or not we try to listen, but also in terms of that listening, getting that information and having it someplace where it can be used and tapped into and thought of as a resource. And so I think that's one of the things that we see the patient-centered core impact set. We see that it's serving that purpose. So I want you to think about in terms of the blueprint itself, the document, and I know I doubt that you've gone through and read every single word of it, but I know that you've skimmed through it. I know that we've had some conversations about it. I want to hear from you about suggestions that you have for the National Health Council in terms of what you would see in terms of reflecting on what you've heard today and reflecting on what you read yourself and your constituents, the people that you represent. Are there things that you would see in there that you would suggest that we highlight, change, add to, delete? Any alterations that, one of the reasons why we're having this dialogue today is because we're in the middle of our public comment period on the blueprint. We want to hear those kinds of comments. So in thinking about your comments, what might those be? What could we do to improve that document to make it something that would be the most useful that it could be and useful to your constituents? So Jen, I'm going to start with you.
Well, first of all, again, bravo on this. I think it's a really well done document. My comments are more reflecting on the panel on how we address the organizational capacity and culture. And so the reason that I am really focused there, our members, they have to review 50 new drug applications a year. So if you think about this, how do they go and find, let's just say you have a set of measures. Where do they go and find it? If they're searching on PubMed, they're searching in Horizon Scanning, are they going to yet another portal? Are they having to go and figure out where this actually exists? So my broadest comment is, how do we make it as easy as possible when all of this great work is out to press the easy button and for it to become available to managed care decision makers? And there's really kind of 4 key points in time that I think it's important. One is Horizon Scanning. About 2 years out, people start planning for what drugs they're going to cover, how they have to change their premiums, about 2 years out. So that's a key piece. 2 is when the drug launches. Within 90 days, most Medicare plans have to make a coverage decision. So making sure that this is available then. And then any ways that we can understand how these the PC-CIS impacts and should inform utilization management, prior authorization, etc. So if there are ways that we need to change how we determine which drugs go for which patients in which care settings, that's better information and that improves the policies. And then last but not least, how do we make sure that all of the incentives are aligned? So it's in the quality measures, it's included in value-based payment models, etc. So it's not so much what's in the blueprint, it's how do we get when the great work comes out of that blueprint so it's readily available. And I think someone said earlier today, or maybe in the comments, make sure it's not on a shelf, that it's readily accessible.
Mm-hmm. Right. I like the way that you put that, pushing that easy button, that someone who is a formulary decision maker who is gathering information about a new drug that either is going to be approved or has just been approved, they're usually doing the usual. They're conducting a PubMed search. They're looking at the dossier that the company has put together with information. They're looking at the resources that they usually go to. And we want to figure out a way that PC-CIS is a resource that they will readily go to. And we've got to figure out where that's going to go. So it could be something like a website that lists all of the PC-CIS that might be available. And then they just have to click on the one for whatever the disease is that they're looking for, or they identify that one's not available yet, but that's something that they will learn to look for, and how we figure out to make that easily accessible to look for. So I think that's a very valuable suggestion. Melanie, anything that you have or as a reaction to how we could make this better, more user-friendly, especially from the patient group perspective?
Sure. I think that it's closely related to what Jen just mentioned, and also looking at the responses about capacity and about cultural change. Maybe some ways of addressing that, maybe some ways that you could have some guidelines about how to approach something when you are coming up with or facing a barrier such as organizational cultural change. And I know that can mean different things for different organizations, what those barriers can be, but maybe some tips for being able to overcome them. And also around capacity, perhaps there's a way of maybe creating maybe a version of the blueprint where you can maybe have a shorter pathway. Maybe there's some steps in the blueprint that can, I don't want to say be eliminated, but somehow accommodating for people who don't have the whole capacity to implement every single step. But I'm not sure if that would ruin the model and the outcome of it. And I think also, I don't remember necessarily seeing a component, but it might be in there, just keeping in mind that they're just different. Patients are very different from one another, and there isn't, one type of patient, and there are a lot of different considerations. And so thinking about, that including the patient voice, keeping in mind that that voice of the patients need to be, diverse, education level, income level, not just kind of the typical things that we might look at to address diversity in our patient pool. Oh, Eleanor, you're on mute.
Yeah, one of your comments made me think about something that we put kind of up front in the blueprint, where we put some basic principles about what we thought were important about the blueprint that everyone should know. And one of the basic principles is we can't let the perfect be the enemy of the good, that we can't expect someone to actually go through the process as precisely as possible and do every single step, and that would be the only core impact set that would be any good. That of course there may be some ways that maybe a preliminary core impact set could be produced because it leverages some resources that an organization already has, but that it would say we intend to do some more primary data collection or something like that. So I think that's a really good point, to put out some what might some interim products look like, interim deliverables look like when someone's on this pathway, so that we're not letting the perfect be the enemy of the good. Yes, Joey, your suggestions about improvements that could be made or additions.
Yeah, so certainly the blueprint is set up very well for its intended purpose. And when thinking about helping patient organizations and others interested in developing the disease or population-specific PC-CIS, I think it's very clear. What I would encourage you to do is to at least be willing to even open up beyond the audiences that we typically think about. When we think about in the healthcare space, we're thinking about, pharma, we're thinking about medical device developers, industry, and that sort of thing. I get that, but and payers and whatnot in the healthcare space. But I'd also challenge you to think beyond, like, what about city planners and mayor's offices? If I know we have a lot of pharmaceutical industry representatives that are going to be interested in new weight loss therapeutics over the next few years. But if your patients live in a food desert, what can that drug do? Or is that drug limited? And so how do we expand beyond our traditional thinking in our, kind of health provider, healthcare system focused space to say, wait a second, we need to bring other members of the government and other members of the population in to have a conversation about how our community is set up. And so I think that really gets into some of the equity issues and having a broader conversation.
Yeah, all great ideas. That's a great idea, Joey. I really appreciate that. So I want to kind of switch gears a little bit and think about something very practical, something very kind of where the rubber hits the road. In your sector or in your area, or maybe in a past area that you've worked in, if PC-CIS existed and there were multiple of them, and there was a place where someone could go to look at them, to leverage them for whatever it is that they're working on, what do you see as the primary uses that you would envision for the organization that you work for, or for the audiences that you work with every day, for the constituents that are part of your membership, or for the stakeholders that you're doing outreach to on a regular basis? And so, Melanie, I saw you nodding your head, so I think I'm going to turn to you first.
I shouldn't do that. But I mean, that's exactly, what you were saying. I was nodding because I can think of several different entities that we work with at American Kidney Fund that would find this very useful. One, I think, if you're just specific to kidney disease, dialysis centers, and also nephrologists, and I would say transplant teams. There are just so many different angles. And I think also with patient groups as well, I think it's important to know from their perspective, how people are working with them, what some of the barriers are in, let's say, clinical practices, or some of the financial barriers or certain things that patients come into contact with as they're navigating living with kidney disease. So, I can see it for clinicians, also patient advocacy groups that are run by patients, and also kind of the service sector for people that are being treated for kidney disease, and maybe there are other entities that are outside of kidney disease for sure. Oh, you're on mute, Eleanor, sorry.
I have to confess that there's been some construction going on behind me in my house. And so I've been trying to keep my mute on so that you're not hearing hammering and drilling, as you might be hearing right now. So my question was, what I wanted to do was drill down with you a little bit on that, Melanie. I'm fascinated by you saying the sector that provides services to kidney disease patients. What would you envision them doing with it? So if they had this, how would they act on it? Can you help us think through that?
Let's say, for instance, if you're talking about the dialysis process, there are a lot of different things that patients need to know about dialysis before they start, so that they're not just kind of jumping into something. Different dialysis modalities, and I'll use an example from the survey that I just mentioned that we conducted around home dialysis. There's a lot of kind of drive from different entities for patients to use home dialysis because it expands choices and the ways someone who's on dialysis can eat, their ability to have more flexibility in their living, ability to work, and things like that. And so I think there's this assumption that a lot of people don't use home dialysis because they just don't know about it or don't understand it. But from our survey, what we found was that people like sometimes going to the center because it's their way of having social interaction with people who are going through something that they're going through. And some people don't want to be in home, isolated, because it takes hours for people to do this. So I think patient advocacy organizations being able to work through this process with patients to know exactly what they want and not necessarily thinking at just solely on clinical outcomes, to know what's best for a patient and pushing a certain maybe treatment or modality, but somehow being able to align what's found in terms of what patients want and what they define as quality of life, not so much from our perspective.
Thank you, Melanie. I think that your example was really a good one. It really helps us to understand and follow the thread all the way through. Joey, I'm going to go to you next.
Yeah, so Eleanor, I'm a policy wonk, so I have to bring it up. I've got on my other screen right now the 700+ page document of the Inflation Reduction Act that was signed yesterday. Section 1191, the establishment of a program. The Secretary shall establish a drug price negotiation program. If any of you have not had the chance to peruse those 700 pages of the statute that was signed, we've got some interesting changes happening in Washington and with our friends at the Centers for Medicare and Medicaid Services. They have got to figure this out over the next few years. They're starting with just a few drugs. So rather than it being individual at different payers and PBMs in the private sector, we have our CMS working on figuring out how to negotiate with pharmaceutical companies, and they can use comparative effectiveness research. So what does that mean? What does that mean in my world? Well, if I'm going to compare drug A to drug B, can I use the core impact set list and say, well, how do you do on this impact? How do you do on this impact? Oh, your drug only does this one thing, but what about these other things? So like, can we evaluate that a little bit? If the drug is very impactful across several of the core impacts, should the company be able to argue for a higher payment because it's more valuable? So like, let's have that debate in a transparent way. That way we make sure impactful drugs are well reimbursed and well paid for, and those that aren't. And so I'm pretty excited. I don't know, again, I know it's just a small step, but I think for all of us who are involved in policy, you have to be thinking about the potential implications over the next few years.
Jen.
Dr. Mattingly, totally agree with all of those statements. And where having a more standardized way to gather and collect this feedback. Oftentimes what's submitted to a health plan will be what's called a format for formulary submissions. It's basically the way to send all of your data about a drug and a disease to a health plan. Well, guess what? In section 3, it usually talks about the clinical measures. It's for multiple sclerosis, it might have how many relapses happened, how many ER hospitalizations occur. Guess what's not in there? Any of the patient impacts. That's in section 5, other supporting evidence. So having a blueprint and a framework that you can hold people accountable to providing credible, sound information that's used, good methods and processes, helps move it from other supporting evidence to those clinical evidence tables. And so then you get to a much different dialogue around what's covered and what's not, because you can have that discussion around, well, this is what you said it was important. Okay, we need to make sure we cover it, even if it's really expensive. Or you said these were the really impactful measures and it doesn't do anything here. Maybe that's not the best use of our purchaser dollars, going back to what Mike Thompson was saying earlier today. And so, it's not just having a credible sense, but having some standards and guidelines to hold groups accountable for that. So we are talking about functional impairment that matters to patients with multiple sclerosis, not necessarily just how many ER visits you had.
All great points. All great points. And in this dialogue, please feel free to comment to one another on something that someone else has said. I don't want to interrupt any of that. I do want to ask you all, one of the things that we have to do, as we've been discussing throughout the day, is we've got to get the word out about this. We've got to make sure people know about it. And so for the worlds and sectors that you operate in, give some thought to what do we need to be doing to get the word out about this so that the right people know. Jen, you mentioned the format and the dossier that companies create, that all of the managed care organizations and formulary committees will have an opportunity to look at. How do we get them to know that this should be part of what they're looking at? And how do we do that kind of dissemination? Any thoughts on that?
I have lots of ideas. One, we just include that. 2 is, how do we put it in the spot where people already go? Depending on where you are, it's easiest. If I'm used to shopping at Trader Joe's, I'm going to go to Trader Joe's. I'm not going to go offline and go to Harris Teeter, even though they might have a better breadbasket, because that's where I go. It's part of my usual routine. I would also just echo, I think there was a comment earlier that Dick Wilkie mentioned about come to our conference, submit something. So that's a core piece. I think there's also a third opportunity. We have many researchers working in managed care research, plus utilizing all of that data. The ability to power these two activities together and think about research within managed care is a really great opportunity. So your dance card is going to be pretty full here coming forward in the next few months and year, but we're really excited about this.
Melanie, any thoughts about that? Helping us to think about what's our best way of communicating, getting out there? What's the marketing campaign going to look like for core impact sets?
I second what Jen mentioned as far as conferences, the key conferences where the target audience is going to be. You know, and I'm not even sure if it's possible to somehow convert a training for continuing education credits or something for people who learn about the blueprint because they have to spend time learning it, and maybe associated workshops or something for implementation. But you know, totally agree with meeting the audience where they're already going.
Joey?
I'll speak maybe a little bit to the academics potentially. I would target as well journal editors, journal editorial boards to think about a more purposeful inclusion or consideration. You know, one of the challenges that we have in the economic space, even though for 20-30 years, we've had our guidelines for best practices for health economics is to do a societal perspective economic model, which includes, you know, caregiver burden, productivity losses, those sorts of things. Even though that's been part of our best practices, 80% of the economic models that are published don't include them. Okay, and that's because journals don't require it. You know, you can throw it in your limitations and say, you know, we didn't include this, and so we need we need to sell the journals on why it's important that researchers, at least if they did not evaluate the items in the impact sets, maybe list why and what were the challenges, and so just to acknowledge them at least.
Similar to this idea of incorporating in whether or not you engaged patients in the research or creating that summary of the research for a patient audience, you know, kind of having some of those kinds of journal requirements that get added in to help with that dissemination. I think that's a great idea. So one of the things that we've talked about today, and that's in the blueprint, is this idea that it would be led by the patient community, that most likely would be patient organizations, but could be other communities of patients, and that they wouldn't be doing this on their own. They wouldn't just be in isolation as a single group going out and doing this and putting it out there and saying, oh, this is it, we've done it, and it's a one and done. That we've really encouraging this idea of collaborations, consortia, that the group would be leading, but it may not be leading alone. It may be 2 or 3 or 4 patient groups that all work in a particular area that collaborate together. And we've seen that kind of activity happen when there have been collaborations and consortia of patient advocacy organizations that put together patient-focused drug development meetings together as a collaborative. And the report came out from a collaboration of organizations, the Voice of the Patient report. So we've seen models of this. What we're thinking about with this is that these consortia would have to be a little bit bigger. They would have to have lots of different patient voices at the table. They would have to have other stakeholders at the table, potentially government, industry, it's professional societies, et cetera. Could you all comment on some of the pros and the advantages and challenges of a large consortia like that? That this wouldn't be done in isolation. It would be done collaboratively with patient group leadership. So patient group leadership doesn't necessarily mean working in isolation. It means leading a collaboration of some kind. And anyone have any thoughts on that who would like to jump in first? Experiences with those kinds of things that you could comment on?
I mean, I'll start just making sure I understand what you're asking. So were you asking what some of the kind of the maybe what to look out for, or what kind of caution?
I think yes, I think it is that. I think it's how can you help that go well? What might be some of those challenges that you might see and how you overcome them, or how you've had experience overcoming them?
I think one of the issues that I've come across when working with patient groups and working with, let's say, professionals, doctors, there's sometimes this fear of intimidation, or this intimidation factor, excuse me, among patients. You know, sometimes they feel like, okay, I don't have all of this background in education, or, you know, I don't have all of this clinical expertise, so, you know, I'll hold back on some of the things that I want to say. Within patient organizations, you know, kind of the good thing is to have a patient that's very passionate, and at the same time, it's kind of a bad thing to have a patient who's very, very passionate, because those patients who have very interesting perspectives and helpful perspectives, who are not as, boisterous and, very outgoing, tend to get drowned out sometimes. So sometimes it's, if there's a way of getting feedback that is not just verbal, and that kind of a setting from people can be very helpful. Some people need more time and, a little bit shyer about sharing. And I think also when working with kind of that mixed industry group, cautioning the experts, so to speak, with using a lot of jargon and technical language, and only looking at it from that point of view, because that can isolate people and make them feel that they're not kind of fit to be in the room, and just cautioning some of the maybe more educated people sometimes who are on the panel, cautioning them about those things and making them aware, but at the same time not being condescending or talking down to people to get the participation.
Right. Yeah, we can see that happening in some of those interactions. Jen, some experiences with collaborations that involve multiple stakeholders.
They're always fantastic in the outcomes. Getting there can be quite hard, especially if each of the groups has different levels of priority. So as I think through this from a payer perspective, I think one of the challenges could be consistency in engagement as you're developing these measures all along that path. If we can better define when in the milestones payers would really need to engage, and or which ones are most important. So high cost drugs that might be going through accelerated approval, pathways where they're approved with perhaps less evidence, those types of rare conditions, things like that, are going to be areas where it'll be far easier for a busy individual to engage or to get support to engage versus the hundreds of conditions that we currently address. So I think those would be a couple of things. And then the last piece I would just say, it's hard to say this now, but the more that we can capture what decisions changed, how did the decision change from we were going to do X and instead we did Y, or it improved our decision certainty. The more that we can capture that, you can help build up the return on investment, because this is going to take different resources. And so how do you, if you're taking this to a chief financial officer or the chief commercialization officer or the chief medical officer and saying, I want to devote X amount of my time towards this, they want to know, how is it going to improve patient outcomes? And how is it going to improve how we ensure that patients get more cost-efficient care throughout that continuum? So really two things: figuring out when you need all stakeholders to be engaged, and two, starting to build up those case studies on the ROI of using the PC-CIS.
Yeah, so Jen, my takeaway from what you just said is that we still encourage in the blueprint the development of a consortium, and that there may be even as many as 15 or 20 groups, organizations that might be involved in something like this, but that they wouldn't be involved all the time, continuously throughout everything. They might step in and step out depending upon when they're needed, because this is resource intensive and someone can't be there every day for every meeting. But there are times when it's more important, in that in putting that work plan together, an organizer would need to think about, when do I really need that organization, as opposed to when is it a nice to have. But they are still part of the team. I would still keep them informed, and they might see something in what I've updated them on that tells them that they want to join the next meeting because it's relevant to them, or they just feel like they've been kept up to date. So I could see that being incorporated in pretty efficiently. Joey, some thoughts on that in terms of consortia, collaborations?
Yeah, my recommendation is to even take a step back and go look at the literature on trust. When we talk about trust between individuals and institutions, how do you get different partners to the table? When you think about bringing a payer, a industry representative, a patient organization, a government representative, all at the table at the same time, they all want something a little different potentially, but they ultimately maybe want the same thing. And how do you vocalize that in a way? Demonstrate some benevolence and that you're willing to be vulnerable and put yourself out there to for the betterment of the body, and try to move forward. The challenge is that we all kind of end up in our own silos and then or unwilling to maybe put things out there because we don't want to risk giving the enemy or the other person some or we treat others as competitors versus collaborators. So I think so this is something we've been battling quite a bit. So at the patients program, we literally were just funded to study this with some of our patient organizations, but we would not have had the opportunity of doing that if we didn't have a 10-year relationship with those patient organizations. So to just reach out to a patient group and say, hey, I'm Joey, can you work with me? That, a lot of people are going to just delete that email. But if you've known me for 10 years and know what I'm about, and I reach out, you're maybe more willing to go on the journey. So how do we just start small and try to build trust? So as you put your consortiums together, collaborations together, you may have to be thoughtful of the size and the ability to interact, and can it have an environment that can foster trust?
Great. So I think we're down to about the last 5 minutes. And so I want to give each of you kind of just a final statement that you could make, your advice to us about PC-CIS and the blueprint and are moving forward with this, and any other reflections that you've had on what you've heard today. So Jen, can I start with you?
Sure. My reflection would be good job. Actually, fantastic job. Keep it up. There are 3 things that I've heard throughout the session. One is this is going to take time. This is a cultural change. So we're going to have to be patient because culture takes time to change. 2 is having a central repository to put these blueprints or to put the measures when they're all available, because going to each consortium that sets that up, I think having a central housing spot is going to be really helpful. And then 3, we'd love to join you on the ride. So thank you, and kudos on a great initiative, and looking forward to watching this continue to prosper.
Thank you. So Melanie, next.
I just want to second what Jen just mentioned with the big kudos. I know this was a lot of work to put together, and considering all the different audiences that can use this tool. One thing I would say would be to, as you move forward, having those use case scenarios for people, I think is really important. I'm somebody, I can look at something in the abstract, but I want to see the application and how did someone do this and what was their experience with it. So I think as people use the tool, follow them and document it. I think that would be very helpful. Great. And thank you again for doing this.
Thank you. Joey?
Yeah, also echoing to what Jennifer said about taking time. Harry Truman in the 40s proposed a healthcare program to help seniors. It took, so when Lyndon Johnson signed Medicare into law in the 1960s, Mr. and Mrs. Truman were the first 2 with a beneficiary card 20 years later. These things take, sorry, I told you I'm a policy nerd. These things take time, but that means we need to celebrate the small wins. Yes, you might put this out here and no one may listen for a decade, but let's just keep trying to plug along, and I encourage you all to keep the baby steps, and then celebrate when the baby steps do happen.
Great. Well, I want to take a moment to thank the 3 of you for helping us kind of be the reactor for what was happened today, to kind of reflect off of those things and to give us your perspective with your different hats on. It's really been wonderful to talk to you about this and to hear from you and get your perspectives. And now I'm going to turn it back over to Annie.